Good day, and welcome to today's webinar, 10 Healthcare Laws All Physicians Should Know. My name is Selena Williams. I am the Program Manager here at Hybrid Solutions. Kelly Jolly is our presenter today, and today's webinar objectives are discuss 10 laws physicians should know to protect themselves and their patients, review success tips for meeting compliance standards, provide an overview of best practices and corporate governance matters. 10 healthcare laws all physicians should know.
Hello, everybody. Thanks for being there today. I'm looking forward to talking to you about this. I always like working with Hybrid, and particularly Selena. She does a great job of getting this together. Today, we're going to talk about 10 laws, and you're going to see on your screen there, we've got a bunch of different laws, all with different letters, because healthcare is an alphabet soup type business. And so we're going to go through these, and I'm going to give you a brief overview, and then I'm going to explain kind of why it matters to you in your practice. And I just want to make sure you know these different things so that you can understand how they might apply and think about whether they're issues that you might should address in your practice. Okay, let's get started. So the Healthcare Quality Improvement Act of 1986 is generally pronounced HICWA is the acronym. It affords peer reviewing bodies and their members legal immunity from liability for suits by the physicians they discipline, so long as certain due process requirements are met. Think of this in terms of peer review at a hospital that you deal with. There's also, of course, sometimes peer review in larger practices, and you'll see peer review occurs. Sometimes there's with reimbursement, different sorts of payers, and as part of the credentialing process. But what we're mainly talking about here is the peer review process in hospitals. So what it says is that the hospital and the physicians that agree to sit on a peer review board or partake in that process are going to be immune from suit for whatever happens there, so long as what they're doing is a professional review action. And that means that they've gone through certain due process rights. Usually in the hospital context, those rights are really about whether you're afforded a hearing. Now, what we have found in practice is that at most hospitals, this hearing actually happens after there's been a decision of the merits. In other words, there's been some sort of physician discipline issue, and now they've come back and they said, okay, we now are going to give you a chance after you've read this thing to have due process. So what ends up happening is the physician who's gone through the discipline hearing ends up really just getting due process at the appellate level. So a lot of times in the basic literature, physicians have found this to be sort of fake due process. Now, it does matter and it does happen, but it matters to you next in particular because if you're asked first to serve in a peer review process, you show that you are not going to be liable for what you say or do there. So here's the things that are required, so that there is immunity for the folks in the peer review process. Whatever happened in that process had to further quality health care. There was a reasonable effort to obtain the facts. The physician being reviewed received notice in a hearing. That's kind of the due process, those two things, notice and a hearing. And the organization had reasonable belief to believe its actions were warranted. Sometimes when doctors come to me after having had a discipline action like this, the first thing they want to tell me is every conversation they had in the lounge where they heard about this and he said or she said. And what I'm always asking is, when did you actually receive notice from the staff that there was a disciplinary matter? And I find a lot of times hospitals or the chief medical officer may have had off the record conversations that the physician thinks were off the record, but the hospital sees as being like fair warning. None of that counts as notice. So when we talk about adequate notice here, we're actually talking about a written notice that is provided to the physician with a date and an explanation of how to respond. And then the hearing is the procedures. Sometimes physicians ask me, should I bother with a hearing? If you don't think something in the notice or in the claim against you is true, you have to go to the hearing. You have to put your side of the story on the record. Why? Because you're going to be asked in the future to list whether you're getting board certified or something else if you've had a negative peer review issue, and you want to at least have made an effort to answer the allegations. And sometimes it works. The other reason it matters is if you have a licensing issue, and most states will require that, for example, if there's been discipline that reduces your privileges in any way, or you're put on suspension or probation, those kind of things have to be reported to your medical board, your licensing body. And a lot of times then they will actually take action based on that. And they're going to request a copy of kind of what happened or what the result was. So you want to create a record for yourself. They'll always participate. The other thing that is important about HICWA is that this is the same law that created the National Practitioner Databank, which is where they put any sort of peer review or other issues that are posted. And this is another question I get from physicians a lot. All right, they posted something about me. I don't think it's true, or we ultimately resolved it, or it happened a long time ago. Do I have to acknowledge this in future job applications or credentialing applications or with my licensing body? And the answer is usually yes. Sometimes questions are phrased in a way that you might say something else, but generally, if you've been reported in any way, you do have to do that. The other thing that's important is that this is where those procedural rules that require due process and set up privilege and reporting matter. The final thing I want you to think about is this system, even though it's frustrating, is important. Right now, I represent the AMA and the South Carolina Medical Association in a case presently before the South Carolina Court of Appeals. And actually, my clients aren't parties. They just wanted us to file an amicus brief, a friend of the court brief, explaining how important this peer review protection and privilege is. Because physicians, frankly, will be unwilling to come forward and acknowledge errors or be honest with their peers in the peer review process if there isn't some privilege assigned. And frankly, the plaintiff's bar is very enthusiastic in their attempt to get access to that confidential information on behalf of the plaintiff. So this is a big policy argument that is currently being litigated all across the country, and it's worth being aware of. Okay. The one thing I just want to, this HICWA only provides conditional immunity, and it does depend on the compliance with the requirements we talked about, that particularly the notice and hearing. So make sure you're getting those if this ever comes up. Okay, next subject, CHIP, the Children's Health Insurance Program. So Children's Health Insurance provides low-cost health coverage to children and families that earn too much to qualify for Medicaid. So Medicaid, helps kind of the poorest of the poor, particularly children. There are tons of people who are what we don't consider the working poor who don't qualify for Medicaid, but quite frankly, can't necessarily afford health insurance either. Now, that is the group that the ACA was intended to help. But before the ACA, children have been helped since 1997 with CHIP. Now, it's a joint federal and state program. It is not Medicaid, but it is in every state. And in every state, it does cooperate in some ways with Medicaid. In some states, actually, CHIP also provides coverage for women, particularly mothers. But not in all states. But in every state, there is a program for children. So they did it because of the number of kids that were without health insurance. It's reduced it by more than half, and it keeps going down. One of the big things is it also really pushed community outreach by providers and by the Medicaid program to make sure people were aware that there was this benefit available. This is a big deal. It's a big deal not only for the kids, obviously, who need the immunizations and the coverage. It's also a big deal for providers like federally qualified health centers, which depend in large part on reimbursement for pediatrics to fund the services they provide for adults that don't have Medicaid or other coverage. So the fact that we're able to secure children and provide services for them through this government insurance program is helpful to those providers and small practice providers that service children, as well as the kids themselves. So what does it cover? It differs a little bit from state to state, just like Medicaid, but also like Medicaid, you can expect it to cover certain basic things. It covers checkups, immunizations, your basic doctor visits, prescriptions, which is a big deal if you think about it, dental and vision care, inpatient, outpatient hospital care, labs, and x-ray services. So basically primary care, including dental and vision, for kids whose families qualify. All right, so what does the state have to do? It all has its own rule about qualifications. So in a given state, you'll have to check with those qualifications, but anybody can actually apply for CHIP through the same health insurance marketplace where they might seek private insurance. And if when you do apply, then CHIP will actually reach out to that. Now, why does this matter to you? Other than our general desire to help kids and other folks. Well, it's important because there's almost 10 million kids enrolled. So it's quite likely that you have, if you serve a family practice or pediatrics, or you work in a hospital setting, you might come into contact with families utilizing CHIP who might be eligible. It's also important if you're a practice manager or someone working in a practice and you see someone, you might not see Medicaid, to think about whether you would accept CHIP and let people know that this is a benefit available to them, possibly, particularly as we go into a recession. And folks may have different sort of monetary concerns. This might be a potential payer source for them. However, again, it is state specific. There's really good materials though online about who qualifies, and it's pretty easy to direct patients there if it might be a possibility for them. Oh, good, we got a polling question. So for this next law, I'm just gonna try to think of a way to make it a little more relevant to you. So a couple of basic questions. Have you ever been asked to invest in a lab or an imaging center? Or have you been offered any kind of free testing supplies by a lab vendor, or for them to collate someone in your practice? If you'd answer that, I think it'll make it a little more germane to what you're doing in your practice. All right, so we've got a couple that have been asked to invest. No one's been offered free supplies. That is probably a good thing. Okay. You can share it. So we had one that had been asked to invest, and two had been both offered free supplies and asked to invest. And so why does this matter? It matters because of the federal Anti-Kickback Act. So let's just talk about that generally. Basically, the Anti-Kickback Act prohibits anyone giving payment or providing something of value to induce or reward patient referrals or the generation of any business involving an item or service that the federal government programs pay for. All right, what does that mean? What it means is you can't do anything and no one else can do anything that might be seen as a benefit offered in exchange for referring a patient to receive a service payable by Medicare, Champus, Medicaid, any federal program. Every state basically this time has what we might call a smaller or a baby Anti-Kickback Act as well. So there's usually a state law component as well. Specifically though, in terms of the Anti-Kickback Act, you have to remember this actually also applies to services inside a group practice. So if one physician in a group practice refers a patient to another physician in that group practice, they want to make sure that that internal referral itself is not somehow violating this act. This is the reason that you have the requirement, for example, that all physicians have written employment agreements. Or if you're an independent contractor, this is why you need an independent contractor agreement. Every so often a practice will come to me and say, we want to be done with these. We don't want to have to do these agreements with nurse practitioners or anyone that can order services. And the Anti-Kickback Act is the reason I say, no, we want to keep those agreements, because having, for example, an employment agreement or independent contractor agreement with at least a one-year term that sets out compensation and makes it clear that that compensation is fair and reasonable based on the services that the physician or provider are providing and not based on any sort of payment for referrals is in those agreements. It's a requirement by this federal act. Now, why do we have it? The reason we have it is that in the 70s, we had Medicare and Medicaid, and there was a goal to make sure that Medicare and Medicaid patients received good advice and that all the referrals were actually for medically necessary services, okay? What the patients needed, and not because of some sort of potential benefit to the referrer. So what are some of the referrals that we see a good bit? Physicians owning a portion of an imaging center. That's a pretty popular thing. We don't see that as much right now, but a lot. Ambulatory surgery centers, right? A lot of times physicians will invest in an ASC And it might be one in which they provide services themselves, but of course, a good portion of it is actually just trying to get some money back as an investment in that ASC, whereas they wouldn't get any money back from providing services if they did so at the local hospital. So those things. You also have the same issue when you have an internal lab, or when someone enters into a contract with a lab company saying, okay, we're going to send our labs to you in exchange for X. A couple of years ago, there was a huge fraud case across the country, and I'll remember the name in just a minute, but basically the whole idea was that the lab company was giving providers free urinalysis cups. I mean, all these tiny little cheap plastic cups. And that they were giving those to them, and that the fact that they were giving those to them was actually illegal kickback, that people were sending folks to this lab because they got the free lab cups from them. We've seen other issues where the labs were paying a fee to staff members inside the physician practice to actually bottle the blood sample or take the blood sample and put it in specific vials that were provided by the lab. And then there was a shipping and handling fee for actually mailing all that stuff back to the lab. That's been alleged to be an illegal kickback. So it's very important, if you are ever asked to enter into one of these lab referral agreements or an ownership agreement, and I have physicians, tons of them have done this. I will say I find it's usually the same ones. There's always a few folks that are really interested in seeing if they can enter into some sort of way to capitalize on the money they see other folks making off their patients. And also there's a lot of times an interest in controlling the output. And that is like, well, I want to pick the lab. I want to make sure I know this is going to be good. The problem we have is that there's just a huge danger for physicians that do enter into these arrangements. Usually, if you are asked, they will provide you some sort of legal opinion letter that they've received from a law firm about the deal. I would always read that. In my experience, the physician rarely does. It usually has several caveats about why they think this would be okay. But what's important for the physician to realize is that they actually can't do anything about that opinion letter. It's not an opinion for them, it's for the business. So there's no like malpractice benefit. If down the road the feds decide, we think that was an illegal kickback. So then you have a situation where you're now having to give your shares back to the company, and you're having to defend this investigation by the feds. If you are asked to enter into any kind of contract, be it with a transportation provider, a laboratory, an imaging center, to invest in any kind of business that might provide services or products that patients that are covered by Medicare or any other federal program would be covered in, you do need to get that reviewed and think about it long and hard to make sure it makes sense. Now, I'm going to tell you this is because the feds are very interested in it, particularly the U.S. attorney's offices. They're particularly concerned right now also about overutilization, increased program costs, the idea that medical decision-making might be skewed based on referrals, where their patients are being steered to the wrong place, and unfair competition. There are, I will say though, you can go next. There are safe harbors that you can use to try and make sure that your kickback, or if not your kickback, but it's your business range, which meets one of those safe harbors, that will save you. If you were caught receiving a kickback, and I'll be honest with you, there are sometimes these things are like blatant, but most of the time, they're not something that you would think of as a blatant kickback. It's an indirect financial or compensation or benefit that a physician or their family is receiving. Then they could be fined, excluded from the federal healthcare programs, which frankly is the kiss of death right now, in terms of actually being able to work as a physician in the United States, it seems like, or jailed. And I unfortunately have seen all of those things happen. So it's worth making sure you get your stuff reviewed. One thing that I do want people to know is a lot of times physicians say, well, I didn't intend for this to happen. The way the anti-kickback law was written, it does not matter whether you intended it or not. It doesn't also matter if you actually provided the benefit. In the example where those urinalysis cups were seen as being a kickback, no one argued that they weren't used for the urinalysis or that the urinalysis wasn't even necessary. The urinalysis was necessary and it was provided and it benefited the patient. And they still said that the money should come back because there were these free cups providing a kickback. Physicians are popular for a couple of reasons. One, everyone knows that particularly if you're a small practice physician or in primary care, you are trying to see as many patients as you can during a day, and you're dealing with a reduced reimbursement. This is true even for specialists now. And it's difficult to make a good living like you would expect and hit all of those payer requirements. So it's attractive to enter into other business arrangements that would see to benefit both you and your patients. However, it's important, as with everything else, that these things get analyzed for both a business and legal perspective by someone other than whoever is offering you this opportunity. Okay, so because remember, anytime you refer a patient to another provider, even someone in your own practice, to the hospital, to an imaging center, to a lab, for certain durable medical equipment or medications, all of those things make you a target for folks in this kind of business. And then fortunately, because you don't have to be intending to commit wrongdoing, to be found guilty, frankly, under this act, it's really important to keep this in mind. All right, sometimes, again, there are legitimate business activities and there are safe harbors. These are all listed out at 42 CFR 1001.952. If you're interested in this is something I could easily send you just a list of these safe harbors. But the ones that I see most of the time are folks that are in a bona fide business arrangement or a lease or something else where there is an actual written contract. Anytime you're trying to enter into a contract to make sure this is going to be okay under the Anti-Kickback Act, you're going to want to make sure that you do have it for at least a 1-year term, and it has to be in writing and it has to set out the compensation. If you haven't done those things, what the services are, what the compensation is for at least a 1-year term, then you're going to have a problem. Even if you are legitimately hired, you have to have that in place. Other things, again, leases, similar thing. Ownership of entities is possible. It's even possible to refer to entities that you have an ownership interest in. You don't have to meet the safe harbor and make sure that you are noticing that. Plus, you need to make sure you're talking with someone in your state who knows your state laws, because your state law may be a little different. As an example, in South Carolina, you cannot actually refer anything to anyone, okay, in exchange. So physicians in South Carolina can't even give like a Starbucks coffee card to a patient who refers another patient. Now, I'll be honest with you, we haven't seen much enforcement of that, but that would be an unlawful referral under the state's Anti-Kickback Act, even though it might be for a patient that isn't covered by Medicaid or Medicare. All right, so here talking now about something else. PSQIA, the Patient Safety and Quality Improvement Act of 2005. When it was signed into law in 2005, it was actually a pretty quick response to a 1999 report from the Institute of Medicine. That's the Health and Medicine Division of the National Academies. And it was like, the report was to err as human, building a safer health system. So what that report found was that between 44,000 and 98,000 people were dying each year in the 1990s by preventable medical errors. And the hospitals were also facing up to $29 billion in annual costs, not counting staff morale issues or diminished trust from patients being, but actual costs from these medical errors. So this law was set up to allow folks to voluntarily apply to be a PSO, a patient safety organization, that could collect and analyze data and help find out where these errors are. All right, so the fact that it's voluntary is important. No one has to report any of these things, but this is how we've gotten a lot of data to assess and resolve patient safety and healthcare quality issues since 2005. So there's different sort of PSOs that have the ability to identify safety issues for different patient groups. And all of this, I will be frank, I'll be able to sure, has seemed to make a difference. I'm kind of surprised, honestly, but it has made a difference. So because there are confidentiality provisions and legal protections, basically the hospitals and providers can actually anonymously share patient safety data without increasing their liability. This voluntary and confidential reporting system is crucial to the whole law. They're not required, no one's required to send information, and the PSOs that are collecting the information and analyzing it are not federally funded. So there is like a working list, and the Office of Civil Rights that actually enforces HIPAA also works on listing and certifying these patient safety organizations. But getting these detailed reports out of these patient safety organizations and their analysis about patient safety events, including near misses, and coming up with best practices has made a big improvement. So it's kind of an interesting thing. This is a situation where there was a problem, folks recognized it, and we actually came up with a way to try and work on the problem without, by creating a framework that wasn't actually based on the stick, right? Or mandatory reporting. It's kind of the opposite of what we talked about before with HITECH and the quality improvement and peer review of physicians. When we're talking about these medical errors in hospitals in particular, these things are being handled confidentially and without an obligation to report. So that's kind of an interesting situation. So basically, healthcare providers can report if there was a patient safety issue or a near miss to their patient safety organization, who will then record it and release it or use it in analysis for future best practices. There again, you'll be protected from liability if you share it under this rule. And that also includes all the information collected and created during the reporting and analysis at the PSO level of the patient safety event. It cannot be used in any sort of litigation or liability proceeding. So it does help because we have this confidential reporting system. We have seen a steady uptick in folks willing to report and to participate. And there has definitely been greater reporting of safety events. We have also, though, seen reduction since 2009, it took like 4 years to get it going, of neglect and safety events in different areas. So it's been a positive thing. We'll continue to see how this system works and if it continues to make a difference in conjunction with some of the other things we've been talking about today, HITECH and this next one. All right. Now, interesting, there are penalties. I said there was no stick. There's no stick for making you provide the patient information. But if you actually violated the patient safety and confidentiality issues, there are penalties. But it's mainly those penalties are for violating the confidentiality portion and in reporting the safety event. Okay. Or if someone gave this PSO the safety information and related about a patient and the PSO somehow released it, there would be a penalty. So there's no penalty if you do not voluntarily report. There is a penalty, though, if you disclose that to someone who shouldn't receive it. EMTALA, I think most people are familiar with this. Emergency Medical Treatment and Labor Act. You can go on, Selena. This is frankly what basically says if someone needs healthcare in an emergency situation and shows up in a hospital ED, then the hospital, whether or not this person has any way to pay for any services, must see that patient and review and either stabilize, transfer, or treat. Okay, so it basically is guaranteeing emergency health care. Now, I actually long ago, probably my second year as a lawyer, we had a situation where it looked like one hospital who would not take the ambulances that would come from certain areas and just kind of kept sending them on. Oh, our ED is full. Our ED always seemed to be full when the patients came from a poor area, but somehow they could squeeze someone in if they came from a wealthier side of town. And all the poorer folks seemed to be going to the county hospital into that ED to be taken care of. And that was kind of a nasty lawsuit between those two hospitals fussing about this that they ultimately resolved out of court, because really, who wants to be in before a jury accused of that? But what we've seen is that this happened back in 1986. This is one of the older laws that we've been talking about. Before this, healthcare providers did not have to provide service if a patient was uninsured or unable to pay, and that included hospitals. So this was a part of things saying, no, we're going to make it so that at least we're going to triage these patients and either stabilize them and then let them go and transfer, or we have to admit them. Next, it applies to folks that are in labor. Basically, if you show up at a hospital in labor, you're going to have that baby there or wherever they can transfer you where you can safely have the baby after you've been stabilized. If you're having a heart attack, stroke, any of those kind of things, broken legs, broken arms, This, frankly, is the reason that emergency departments have in many communities become the de facto healthcare provider. If you show up in an actual emergency condition, they have to help you, right? They can't transfer uninsured or Medicaid patients to other hospitals unless they have actually screened them to ensure they're stable for transfer, and that other hospital has to accept them. So if they're not willing or to provide the service, they have to transfer the patient to a capable facility who has agreed to take them. All right. Okay. So there's two main provisions that apply specifically to physicians in EMTALA. The first is there is a penalty for a physician who fails to respond to an emergency situation when they are assigned as the on-call physician. So you're a physician on call in the ED or any situation in the hospital, and you don't respond when you're supposed to, well, you'd have the issues under whatever call contract you have. You'd have your staff issues that were requiring you to apply for call, or if your practice had a contract with the hospital, there would be those contractual obligations. But this is also a statutory one, and there would be a penalty from EMTALA if the patient was harmed and there was an EMTALA violation and you were the physician on call and did not show up. There's also liability if a physician signs a certificate in support of an appropriate transfer if they knew or should have known that that patient was actually not stabilized and able to be transferred. So if you're in that situation, this is the thing you need to understand, that when you sign that transfer certificate, it's not simply a malpractice situation where they would have to prove negligence. There's also a statutory penalty that's possible. Okay, so here we have our next polling question. This is just simple, trying to see where y'all are. Are any of you planning to hire a new physician in the next 12 months, or did you hire one, I guess we should say, in the last 12 months, or do you expect to seek a new job in the next 12 months? If you would post that, Selena, we just see if we get a little idea of that. We got 10 responses for that. We got a couple of job seekers. The rest are staying put. Can we go ahead and do the next poll question, Selena? And then
Yes.
I'll use those two to address this next.
Okay, we're going to launch the third poll question. How many physicians are in your practice? I'm going to launch the poll.
Thank you. And I actually didn't think about this. I probably should have put down here whether any physicians on here were actually employed by a hospital. I didn't. If that was the case, just go ahead and sign up under more than 10. And it might not be, everyone might be from smaller practices. I just want to be sure before we talk about this next thing. Okay. Anybody else can answer on how many physicians are in your practice?
Yes, I think everyone has answered on this one, Kelly.
Okay.
So we'll end this one and share the results.
All right. So we're looking mainly at smaller practices here. All right, that's good. Let's go on then to the next topic. Okay, so now we're going to talk about Pete Stark's law. This is the physician self-referral law. A lot of times you'll hear it talked about with that anti-kickback statute that we talked about earlier. It's actually that, I think I probably said Anti-Kickback Act or Anti-Kickback Law. All those things are correct. But when you hear them talked about together, what you'll see is you usually say Stark and AKS. So that's the Anti-Kickback Statute and the Stark Law. All right. So what is the Stark Law? The Stark Law first of all, only applies to physicians. It does not apply to nurse practitioners. It does not apply to nurses or hospitals or anyone but specifically the physician. It's called the Stark Law. It's the physician self-referral law because it was originally drafted by Pete Stark. And what it does is it prohibits physicians from referring patients to receive certain what are called designated health services that are payable by Medicare or Medicaid from any entity with which the physician has a financial relationship. It's actually a financial or an ownership relationship. So if there's any sort of remuneration, any sort of compensation, benefits, and this includes to the physician's family, then that would be, and if it's only for designated health services. So when we're doing like a decision tree, what we end up going through is saying, okay, first off, are we dealing with a physician? Secondly, are patients receiving a designated health service? Now, what's tricky is designated health service includes things like labs and physician services and imaging and certain durable medical equipment, not all of it, but some. Surgical services. So it refers a lot of those things. We've had this law since the 1980s. This was actually enacted in 1989 to prevent any financial incentives from improperly influencing medical decision-making, just like we just talked about with the anti-kickback statute, all right? Again, the idea was that physicians should not be able to benefit financially from referring patients to other places for services where they have a behind-the-scenes financial relationship. It's understandable, but there are also some things that frankly don't make sense about it. This, for example, is the reason that a lot of times you'll see nephrology practices in an office suite next door to a dialysis clinic. They're not the same business because under the Stark law, the dialysis clinic cannot be owned by those physicians and then have the folks that are receiving dialysis actually receive funds from Medicare or Medicaid for those services. Okay, next. So we'd asked about, okay, there we go. There's three main provisions. First is that healthcare providers cannot refer Medicare, Medicaid, CHAMPUS, TRICARE patients for these certain health services to a business in which the physician has a financial or familial interest or any kind of ownership interest. It prohibits the billing of Medicare or other insurance providers for health service anytime an improper physician referral is made. Now, there are several exceptions here too. There are safe harbors, but I want to focus for a second on two because, for example, right now, I'm defending a physician from a U.S. attorney's civil investigative demand, and they're clearly looking at various lab arrangements. Now, my physician actually was not involved in the lab arrangements. It seems like the U.S. attorney is curious about because they've asked for several specific lab contracts that are not present. But it's clear that what they're looking to find out is whether there was some sort of financial interest by the physician in one of these lab partners that the physician referred to. And if they found something like that, what they are seeking is to actually recoup all of the money that Medicare reimbursed a physician based on one of these referrals. As with the AKS, it does not matter if the lab was actually performed and medically necessary. They would still seek the full value back of the reimbursement if they found that there was any sort of referral that might be prohibited by Stark. That's how that's working. Next. So what are the designated health services? Clinical labs, physical therapy, OT, outpatient speech language pathology services, radiology, radiation. That includes some supplies, certain durable medical equipment and supplies. You'll sometimes see folks get arrested for, selling fake wheelchairs or something to people who are not actually needing them. That's kind of how that goes. Parenteral and enteral nutrients, equipment and supplies, prosthetics, orthotics, outpatient prescription drugs, inpatient and outpatient hospital services. So all of those things, if any of those were referred to, the patient received any of those based on a physician referral and there was any additional relationship, then that could be the start. So it's a strict liability statute. You don't have to have intended to violate it to actually be found liable. To avoid violating it, you have to consider making sure you have your healthcare employment contracts in place. And this is specifically why I asked those two questions. First, you want to make sure you review all of your physician agreements at least every year, okay? And if you're in a small practice, there's no reason not to, but you want to make sure that you've actually written those and that everyone is kind of under the same contract and that it sets out what they're actually receiving as compensation, including benefits and CME reimbursements and travel and and your practice dues and all those kind of things. Making sure you have all of those in place. You want to make sure you have a list of all potential conflicts of interest. If any physician's family works for another entity. I have a client who desperately, the wife of the physician wants to buy this building that is on the grounds of a local hospital. And the physician does not in any way work for the hospital, but he does, of course, refer patients to the hospital. And he also owns a building right in this little medical practice community. And the wife of the physician is having a very hard time actually getting the opportunity to buy this building, which has been empty for 3 years, specifically because the hospital was afraid to do anything that might look like they were selling that building to the wife of a physician in the community and come up with a stark violation. You want to make sure you have a document of all payments between parties. And this does include that you want to make sure you make it clear that if you do refer folks for labs or you do anything where you're billing part of it and then paying the lab for providing services or whatever, that you keep a good detailed records of all of those payments for 8 years. Okay, next. The Genetic Information Non-Discrimination Act, GINA of 2008. This was just pretty straightforward. It does what it says it's going to do. It basically protects American citizens, this is one was covered, from discrimination based on their genetic information from health insurance or employment. So just because you have markers that you could develop breast cancer down the future and all of your family members have breast cancer, health insurance cannot use that genetic information to determine what your health insurance premium should be. It's signed in 2008. And there's two parts. Title I prohibits health coverage, so insurance, and Type 2 prevents it in employment. So employers similarly can't find out genetic information on their employees and decide to terminate or make any decisions based on what their genes say might be the case in the future. So genetic information doesn't just mean that we've actually done like a blood test. It also includes more generally family medical history, disease and family members, information regarding individuals and family members' genetic tests. So it is an interesting thing now that so many people voluntarily actually go do those 23andMe or different sorts of home genetic tests. But there was a real fear initially back when they started this, that folks would be doing these tests and the information would come out and there could somehow be discrimination. We so far haven't seen that except in science fiction movies, but there is certainly a concern about it. And when we've had cases and enforcement, it's frankly usually been in the employment context. But again, health insurers cannot use any of that information to make coverage, underwriting, or premium setting decisions. All right. Now that doesn't actually impact long-term care. That does impact actual health care. All right. The EEOC is who implements Title II, and you can't hire, fire, promote, pay, or make it a job assignment based on someone's genetic or use genetic tests as a condition of employment. So that's that one. That one's a pretty easy one. It doesn't apply if you have fewer than 15 employees. So it doesn't apply to a lot of small practices. It does, but you'll see that if it is 15 employees or not, it does still provide a privacy safeguard regarding personal and family genetic information that is actually apart from HIPAA and has separate enforcement provisions. Really, this is a law that has been put into place against future discrimination as opposed to what we're doing right now. HITECH, we've talked about HITECH in hybrid seminars before. Go on, Selena. Basically, it was created to promote and grow the adoption of health information technology. When this came out, the goal was for everyone to have an electronic health record within, I can't remember how many years now, but the idea was that every person in the United States would have an EHR that could be used and would follow that patient as they went from provider to provider. And the HITECH Act was really set up to do that. Now, before that, in 2008, only 10% of hospitals had adopted EHRs. Here we are 14 years later. Not only does every hospital have probably in their third iteration of an EHR, most of them are networked in some way through a health information exchange. We're exchanging claims data and clinical records electronically. And most physicians now actually have an EHR, in part thanks to people like Highbridge, who helped everyone kind of adopt EHRs to begin with. Initially, there were incentives to encourage hospitals and the healthcare providers to make change and move over. And what we've seen is that even by 2017, 86% of office-based physicians had implemented EHR, and 96% of non-federal acute care hospitals had added like certified health IT. I actually think that's higher now. I think it's 100%. So there were 5 goals. They wanted to improve quality, safety, and efficiency. They wanted to engage patients, increase coordination of care, improve population health, which is a big thing. Actually, population health was not really talked about before the HITECH Act, but it is a huge thing now. And then and because of all this, if we're sending the data around and we're making it more available and we're making it electronic, they wanted to make sure that there were privacy and safety provisions in place to protect that. They did not actually create a whole new privacy law. What they actually did was they went back to HIPAA, which had been in place already for 15 years or so, and said, hey, let's increase the penalties and provide mandatory enforcement for HIPAA. And that's what they did. So the HITECH Act put HIPAA on steroids a bit. It has 4 parts: health information technology, testing, grants and loan funding, and privacy. Privacy is the one that probably impacts most of y'all the most. Next, it's where you have these, this is where meaningful use came from initially, but we can go on. I just want to talk about what it matters. Okay, the one thing I want you to say is that the HITECH Act is why sometimes you'll have plaintiffs' firms, for example, come in and say, we want to have all of your records and we want to pay you $5. There are specific privacy provisions in the HITECH Act that said what you could actually pay, and what you can pay, or what you can charge a patient for records is actually the cost of providing that record to them. There's a safe harbor you can pay, which is low, but if you actually wanted to receive funds, you have to do the cost, meaning the cost of labor, the cost of paper, cost of toner. It can't just be a flat fee. So other than the safe harbor numbers, that's where that's coming from. All right, False Claims Act. This is frankly the oldest thing we've talked about today. It's a federal law that makes it a crime for any person or organization to knowingly make a false record or file a false claim regarding any federal health care program. It actually was passed during the Civil War because there were various contractors that were taking advantage and saying they were doing things and providing services and equipment that they were not, in fact, providing to the United States government. And so the response, Congress passed this law, making that a problem. It's illegal to submit claims for payment or actually any kind of form to the government. So if you receive any form from the government or from Medicare or from Medicaid and you fib in any way on that form, that is an actual violation of the False Claims Act and could be prosecuted. But more commonly what we see is the billing for services that weren't rendered or selling equipment that wasn't actually necessary, physicians saying it was. I've had physicians prosecuted because they were the medical director of a business that was providing both legitimate services and maybe not so legitimate services. And the physician had provided like a stamp, and all of the orders for urinalysis or all of the orders for labs or imaging or what have you were going out on that physician's signature. So it's important as a physician that you understand the rules that relate to services and the goods being billed, and that you know what contracts are in place, and you know every single place that your signature is being used, okay? Some of the very nicest people I know are the physicians that get in trouble the most because they tend to be a little too trusting, or they've signed a bunch of different medical director agreements and they might not be actually paying attention to what is happening there and not be aware of the claims filed under their names. So anytime you're concerned about whether something has been done or might not be right, it's important to report it as soon as possible. I did have a physician who finally realized that this business was actually submitting claims for example, I think it was a kind of cream that was not necessarily the right cream and was completely not medically necessary. And they were all out under his name, and he actually reported it. And I'm happy to say that in that scheme, there's one person not in prison, and that would be this physician that we represented. So it is important you make sure you bring it to the attention of folks who should know really quickly. All right. Last, the Fair Labor Standards Act. This is not specifically medical. This one is actually an employment law. It is a federal law that creates the right to a minimum wage, says who is eligible for overtime and what they get paid, and what record keeping is required for full-time and part-time employees at both the state and federal level. In the South, a lot of times we have pretty liberal or employer-friendly, we should say, employment laws. And so there are a lot of times there's not a lot of state law that applies. So you might have a state minimum wage and you might not, in which case you'd be following the federal one. This is an old law too. This is actually from 1938. This protects workers from abuse and stop child labor. Right now, I just find that a lot of folks are very confused about who is an exempt employee and who is a non-exempt employee. Whenever we talk about exempt or non-exempt, we are saying whether or not someone's position means that they are exempt from FALSA. Okay, this is the law we're talking about. So anyone who is a covered means they fall under FALSA, they're an employee. Non-exempt, meaning that they are just paid a wage. They must get a minimum wage for all hours worked, and they have to be paid overtime for hours over 40 in a work week. It has to be based on the actual hours of that week. Sometimes folks will think, well, I could do a 2-week pay period, and over the 2 weeks, the employee worked less than 80 hours. That is not how the law works. If you work more than 40 in any work week, you have to be paid at least half the regular rate of pay for overtime. One thing that does seem else, records have to be kept for at least 3 years by the employer. I find a lot of employers get this a little confused. They either keep records for everyone, including salaried folks. In other words, folks who are exempt from FALSA based on their job responsibilities, or they don't seem to have pay records for anyone. If you don't have the pay records and you get dinged or an investigation, you're not going to be able to prove that you handled things right. It's really important to understand that. I don't have time today, we're at 12:56 to talk about that, but if that is something you have a specific question about, feel free to pass it on to Selena or reach out to me and we'll be happy to talk about it. All right, are there any questions, Selena, before we finish up?
Let me see. We don't have any questions, Kelly, in the chat or in the Q&A.
Okay.
So thank you so much. That was a lot of valuable information.
You're welcome.
And we got through it. It's 12:57.
All right. Good. Well, thanks everyone for attending. And if you have questions down the road, happy to help.
Thank you, Kelly. And again, thank you all for attending. Just wanted to share this slide regarding our continuing education that we provide. We partnership with Formed Plus for online continuing education. It is designed to meet the busy needs of the healthcare industry professionals. And so we have a discount here. We've had lots of providers that has participated in this and taken advantage. So if you're interested, just reach out to us and I can share this information. Hold on one second, Kelly. It looks like we do have a question. Okay, so we have, there's a provider, a manager on here.
Okay.
Practice manager says, can clinic rent its space from an employer or manager? Let me see if I can
healthcare
unmute.
clinic.
Yeah, I think he's
maybe
can. Like a satellite.
So you can actually, a clinic can rent a space from a physician owner or a manager or anything like that. What's important is that contract, that lease, meet the safe harbor requirements. It has to set out the timeline. I mean, the time frame of the lease. The lease needs to be for at least a 1-year term. It has to set out the compensation, which has to be the fair market value. In other words, the practice can't pay more for that space than another business would. You need to kind of done a fair market value analysis. And then you have to keep that in place. You can amend it if necessary once in the term, 1-year term, but you can only do it once. Then it have to be studied. But you can do that. It just needs to be a written contract that meets the safe harbor requirement.
Thank you, Kelly, for answering that question.
Ma'am.
If there are any additional questions, feel free. Here's my contact information. You can reach me via email and I can pass that on to Kelly. Thank you all again for attending today. Have a great day.